A warm welcome to our satellite participants. I hope you'll agree that this has been a terrific day with excellent speakers, provocative discussions, and a focus on solutions. Our final panel, Public Health and the New Administration, Impact on the Future, promises to be equally stimulating. My name is Sarah Strunk, and I'm Director of External Affairs for the School of Public Health. I'll be moderating today's discussion, and I'm joined by co-presider Felicia Solomon, a master's student in the Department of Health Behavior and Health Education. With us today are 6 distinguished professionals. Each panelist is highly regarded, and I encourage you to review their biographical sketches in more detail. Please join me in welcoming our panelists, and please hold your applause until all introductions have been made. Dennis McBride, North Carolina's State Health Director and Assistant Secretary of Health in the North Carolina Department of Health and Human Services. Dr. Joel Schwartz, Adjunct Professor in UNC's Curriculum and Public Policy Analysis and University Professor of Distinguished Teaching. Dr. Marian Thompson, Director of Education and Biomedical Research Development at the National Institute of Environmental Health Sciences. Ms. Jacqueline Resnick, Director of UNC's Proposal Development Initiative, a pan-university program to promote multidisciplinary and interdisciplinary research. Dr. Bill Jenkins, Supervisory Epidemiologist in the National Center for HIV, STD, and TB Prevention at the Centers for Disease Control and Prevention. And Dr. Janet Sutherland, Chair of Hospital Dentistry and Director of General Dentistry at the UNC School of Dentistry. Panelists, thank you very much for joining us today. I know the audience is eager to have their questions answered, but first I'm going to ask a few general questions to get us started. Then we'll open the discussion to questions for the audience. So let's begin. We're not yet 30 days into the new administration, yet already we've heard about a variety of plans and proposals. When the dust finally settles, what initiative do you think will be implemented by the Bush administration to address health disparities, and what opportunities will arise as a result? Dr. McBride, would you like to get us started?
I'll be happy to, and I'm, first of all, I'm very honored to be here, and it's a wonderful occasion that I've been here for this, I think, my 3rd conference. It's hard looking into the crystal ball in terms of what the present administration is going to do, but there's some interesting pieces. I think you can sort of say what's not going to be done in a lot of ways. I don't think there's going to be very a lot of structured programming and, of course, regulations in regards to health and environment and those kinds of things are going to be very difficult. But one of the things I think is going to be interesting is the initiative on the faith and community initiatives that's been voiced. And I think with that gives an opportunity for those of us who are in public health, and I know that there's a rich history in North Carolina in dealing with community-based programs and especially faith-based programs. I think that's going to be a tremendous opportunity. But what that offers is a very tough challenge because we talk a lot about community-based organizations, supporting community-based organizations and the like, but we don't really structure, we in the government don't structure ourselves very around community organizations in our systems. And often community organizations have difficulties in starting, difficulties in maintaining and the like, even though they might be the only source of a given care. So I think the implication for us will be that community-based organizations are going to need nurturing and help from the formal structures and other large community organizations. But it also means that that entrepreneurship will be, and public entrepreneurship will be rewarded in this setting. So I would say that if I had my druthers out there and I want to deal with this administration, I'd be looking at community-based organizations and entrepreneurial ways of getting them started and getting them supported.
Okay. Thank you, Dr. McBride. Would other panelists care to comment?
Could you please show the? Okay. In my judgment, in my judgment, the most important personal and public health problem facing the African American community today is the epidemic's level of AIDS in the African American community, which you can see displayed here. In fact, 2 weeks ago, the Center for Disease Control issued a report citing the incidence rate of AIDS among gay males. Among black gay males, the incidence rate is 30%. The author of that report called that figure astonishing and compared it to levels of infection which we find only in some African countries such as South Africa, Zimbabwe, et cetera, and so forth. Essentially what's going on, and of course this is concentrated in the urban black community, which has always been already marginalized in so many different ways. What can we expect from the Bush administration in terms of responding to what can only be called a kind of demographic genocide which is occurring in the urban black community? I think we can expect absolutely nothing whatsoever. And I will tell you why I believe that is the case. If you look at both his campaign promises and proposals and what he's got on his agenda, there's only 2 health issues that he is even interested in addressing. One is to provide corporate welfare to the pharmaceutical industry, which is the most profitable industry in the world, which will simply drive up the cost of pharmaceutical drugs, which is already the fastest growing component in healthcare costs in this country, which now represents 10% of the more than $1 trillion we are spending on healthcare. The other is to provide some kind of subsidy or tax credit for the 42 million Americans who have no public health insurance or private health insurance. This will be useless because most of these people, A, don't pay any taxes, so a tax credit is useless, and the amount of subsidies it's going to provide will be wholly inadequate to get any kind of, insurance. Now, why will he do absolutely nothing about this issue? Because if one looks at his record as governor, and I'll just cite 2 instances, and of course, Mr. Gore tried to bring this to the attention of the American people, but they didn't care about that for one simple reason. Americans do not care about the problems of the uninsured. Americans care about improving their insurance benefits, not about those people who have no insurance benefits whatsoever. And so even if Al had pushed the matter more aggressively, which I think he should have, it wouldn't have made any difference. Now here's the governor who's the governor of the state of Texas, which ranks first. 25% of all the people living in Texas have no health insurance whatsoever. Secondly, here's a governor who, when we passed a program and they appropriated $28 billion to get it started called CHIP, Child Health Insurance Program, Texas ranked almost last in the number of children were enrolled. When asked why more children had not been enrolled, this was his answer, that the Texas legislature meets only once every other year, and the CHIP program was passed right after the legislature had concluded. But if you look at the Constitution of Texas, as every other constitution, the governor has the power to call an emergency session. And you saw that the governor of the state of Florida, not the governor, but let's say a surrogate of his, quickly called a very quick emergency session of the Florida state legislature for a very important reason, to make sure George Bush got their electoral votes. Did George Bush do any of that regarding CHIP? Absolutely nothing. He waited for the 2 years, and the problem with that, and CHIP, use it or lose it. So I think looking at his record in terms of being, quote, a compassionate conservative, leaving no child behind, he has left more children behind in the state of Texas than anybody else has left in any other state in the United States. So I don't believe we can expect much from him. Now, one last point, and I will then yield. I say this as a political scientist. Whether it's in Washington or in Raleigh, politicians do not do the things which ought to be done. They do the things which will benefit them in terms of campaign contributions, in terms of votes, in terms of volunteers to be reelected. Let's face it, George Bush will not benefit in any way if he helps the African American community, because they gave a larger percentage of their vote to Al Gore than they gave to his predecessor, Bill Clinton, in both the 92 and 96 election, in case you're not aware of that. The Black Caucus walked out. Congressional Black Caucus walked out when they counted electoral votes because they said these were fraudulent. And the NAACP is suing the state of Florida at this very moment about the disenfranchisement of black votes. Now, he obviously is not going to make a big dent in terms of the next election, whether it be 02 or 04 in the black community. So what does he have to gain politically from addressing this issue? Nothing. And therefore, he's going to do nothing. One last possibility is his, what is it called? Health and Human Resources, Tommy Thompson. What did he make his reputation on? Welfare reform. They reduced it by 90%. That law comes to an end in 02. I guess what he's going to be focusing on. Getting that law reenacted with revisions, and I don't think he's going to throw one penny, one person at this issue, which frankly, to me, is a criminal indictment of this country.
Thank you, Dr. Schwartz.
I'd like to address the same question, but first of all, I'd like to specify that I'm with NIEHS, but we are an institute of the National Institute of Health, the agency that is charged with addressing the biomedical health research and training needs of the American people. And I agree with the previous speaker that there's no track record there, and so we'll have to wait and see. But I'd also like to remind you that the way we have our transfer of governments, and for the most part, history will show that we transfer on the programs that are ongoing. As far as the National Institute of Health is concerned, some of you may know that just a couple of weeks ago, the new director for the National Center of Minority Health and Health Disparities took office. Now, that occurred in this administration. Obviously, it is the result of activities that have been going on for a long time. But that center is up and it's running, and its primary function is to address health disparities. The other issue that I want to bring to your attention as we are in this new administration is that probably you all are familiar with Healthy People 2010, and it has two major goals. The second goal is that of eliminating health disparities. That is a program that will continue. I also want to bring to your attention that Surgeon General David Satcher has placed in his priority health disparities. And he is guiding Healthy People 2010. Dr. Satcher will be there for another year as Surgeon General, so we expect that program to proceed. I'm very, very happy, and I'm very optimistic about the National Center for Health Disparities and National Center for Minority Health and Health Disparities. And I think that there are a lot of things that can be done, that will be done, but I'd also like to tell you or to remind you that the government works at the charge of the people. And that's not just one person, because obviously one person doesn't have that much of an effect. But I think it's very important for individuals to combine forces and tell the government what you want.
I'd like to build on what's been said before in a couple of different ways. What does this all mean for you? Some of you are already health professionals out in the state and around the country. Others of you are soon to be out in the community, graduating from School of Public Health that provides advocacy as one of its key roles for the people that you're about to serve. Now, the Bush administration has indicated in their policy for the uninsured that for those people who don't qualify for Medicaid and who are uninsured through their working situations, that they will get a $2,000 tax credit. What does that mean in terms of buying health insurance for a family? And what does that mean to people whose average income, when we look at underserved and hard-to-reach populations and minority groups, when the average income is $16,400, the median is $16,400 a year? And what does that mean for you? What are you going to have to do in order to provide access to health care? The Bush administration is indicating that they will put forth greater funding for health centers. But at what cost? What will you be able to provide? Let me read you something about the history in Texas that builds on what's been said. When it became time to appoint a new state commissioner of health, Bush found an anti-abortion advocate in Dr. William Archer, who was willing to assert, in spite of Texas's terrible health statistics, providing insurance to the uninsured would not change anything. Archer, the son of retiring U.S. Republican Bill Archer from Houston, has been a longtime proponent of abstinence-based sex education. As a mid-level federal official under former President George Bush, he was the chief defender of the now-defunct regulation, the so-called gag rule, that barred workers at tax-supported health clinics from discussing abortion with pregnant clients. That's what you're going to be facing. These are the issues. So what can you do to try to build coalitions, provide partnerships, and look for additional funding that would allow for people to have access to care based on the initiatives that will be put forth by the Bush administration?
I guess I'm supposed to say something, huh? Well, Abraham Lincoln said, you can't fool all of the people all of the time. But in the Reagan administration, we found that you can fool most of the people most of the time. And from a political point of view, that's really all you have to do. To the extent that the Bush administration makes it clear that it is the responsibility of citizens to make a difference in America, it is a very good thing. But if you expect some great new effort that's going to end the disparities, close the gap, then I think, it's going to be a very difficult thing. The one thing that I would say on this particular question is we have a tendency to use words like leaders and see politicians as leaders. They're not leaders, they're followers. They're people who find out where you want to go and then try to jump in the front. So if you make it clear that where we want to go is to end disparities in America, we will continue to end disparities in America. And if you don't make it clear that that's what we want to do, it won't happen. Example, a week and a half ago, White House announcement, we will close the AIDS office. White House board lights up. Next day, we will not close the AIDS office. It is up to you.
I'd like to build a little bit on what Dr. Thompson was talking about in terms of the initiatives that have already been started under the past administration, which is initiation of a lot of programs underneath the National Institutes of Health and other agencies that are associated or related to health. And those programs, I think, are the things that are going to take us to the next step in closing some of the gaps in health disparities. But there are some other things, I think, that we need to do on the grassroots level, and that is, as practitioners, as healthcare providers, we have to be the ones on the forefront to do some of the things that are necessary to close the gaps. I think the politicians, the Bush administration can, issue the policies, they can take away the monies and all of those different things, but we are actually going to be the ones that those folks are going to be looking to for help and for closing some of the gaps that exist. One of the things that the Bush administration can do is actually provide monies to train more professionals. There's a lot of you out here, there's been a lot of folks here today, but actually putting those individuals in the places where they're needed has been the most difficult thing in terms of health care and providing health care. And that is why we continue to see the disparities that we see. It's not so much that there's not monies there and there's not programs there, but the bodies to be there, to actually provide the care, to actually close some of the gaps. Those are some of the more pressing issues that we face. The smaller counties in North Carolina and other states, we train quite a few physicians, nurses, dentists, but can we get those folks to those areas? Can we give those folks the services they need? And in order to do that, I think it's going to require a great deal of collaboration, facilitation, a lot of community-based programs to find out what the needs are. Those things can't come from the top. They kind of have to come from the bottom. We have to figure out what it is that the people need, the ones especially that are in the situations where they have most of the, or bear most of the burden for the disease and problems, social problems.
I have one other.
I'm sorry.
Go ahead.
I think we need to clear up
Sure.
about fooling most of the people most of the time. There was already an Office of Minority Health headed by the same person who's heading the new one. And that office had a budget of $17 million a year. A significant amount of that money turned back every year since that program was in office. That budget was then requested at $21 million a year. That's only $4 million more. So the idea that there's this new center, in quotes, and it's going to do all this work is bullshit.
Excuse me. No,
But how do you really
Now,
feel?
hold on one thing.
We're on
what has
TV, watch
happened-
it.
What has happened is that there is now an attempt to appropriation of $130 million. And that might make a difference if the same staff wasn't there. But I'm not sure what this means, because although Congress can appropriate, it doesn't necessarily mean that agency has to spend all of the money. I think, again, let me give you one other example of fooling most of the people most of the time. In the early 1970s, under the Reagan administration, and partly the Carter administration before that, this country entered into an effort to start a new medical school here in the United States, a black medical school here in the United States. But at the same time, funds to black medical school generally did not increase. And so while the number of black medical school increased by 1, the number of spaces of black medical students actually went down by something like 37 seats. So that here you have situations where the vast majority of health professionals will stand up and cheer and clap at the same time that the actual number of positions were going down. You can fool most of the people most of the time, because most people don't look at the numbers. What they saw was a wonderful institution being opened and a lot of fanfare, and people jumped up and down and clapped about that issue without realizing at the same time what was happening was that the number of positions were going down. And I think that what people need to do is make sure that they're looking at the numbers.
And Dr. Johnson-Thompson,
Just
did you?
wanted to, before I say what I was going to say before, Bill, those numbers for ORMH were 80 million. And it's my understanding that the 131 for the new center has been appropriated. I know nothing about money being turned back at all. What I was going to address was a new initiative that I think that will be coming down the line. And the two speakers sort of addressed the issue that I might not have said as clearly as they followed through on it about really taking advantage of opportunities. I had to go back to my office during lunch, and I happened to look on my computer, and there was today's edition of the Washington Facts. And so there has been a House resolution submitted by Republican Randy Cunningham to establish the Office of Men's Health at DHHS. Now, I think that this would be an opportunity for minority men and ethnic men to say, what are we going to get out of this? So that's an example of something that will probably come down the pipeline, but individuals will have to be ready to take advantage of it.
Can I? Since I had the first crack, I was really trying to be nice and mild, but the level has gone really Not that I'm going to try to keep up with it. I'm not going to try to keep up with it because I might lose my job. But in talking to those of you who are students and talking to, and I do want to caution you because sometimes we in these positions get so caught up in the politics of things and the immediacy of things that we often lose sight of that the things go on. And if I would venture to say, if even the president had put all of his political shoulders behind dismantling the huge bureaucracy around health and deal with the 1-point-something trillion that's going out to medical services, he couldn't do it. There is a lot of machinery and what have you that's already there, that will be there, that is going to be there no matter what the politics, as distasteful as some of us might feel this politics are, no matter what the politics are. So I think that my father used to say, well, when you see the crowd go this way, you go the other way. And I think especially those of you in the field, those bit of you who are contrarians and looking at health in a sort of idealistic way, I think there's going to be opportunities within this system as it goes towards that. When I say working with communities, I'm serious about it, and I think there is wonderful opportunities in working with communities, more than just the rhetoric of working with communities and faith-based organizations, and that's where the action is going to be. And in fact, if you start talking about power and resources, that's where the power and resources will be actualized. So if you are trying to look for let me just give you an example in North Carolina. Right now in North Carolina, we virtually have no ethnic leadership in local public health. We have 87 health departments, and right now there are 2 people of color in leadership capacities there in North Carolina. It might be less than that later on. Virtually wipe out. Now, there are opportunities to run health departments in North Carolina and other states. So there are opportunities to, in fact, shape how local health can be developed in your communities. That's not going to go away with the presidency. It's not going to. It's not hinged on who the president is and who the president is not. So I'm saying, what I'm putting forth is that don't be too caught up in the latest of a fund here and a fund there. Look at the bigger picture and look at what is right before you in terms of opportunity. They're not going to get rid of this hall here, okay? It's going to be here. They're going to have a conference here next year, I believe. They're going to have the conference here next year. So that's why I mentioned be entrepreneurial. Look at opportunities that are right there. There are opportunities and resources that are right before you.
Dr. McBride, I think that's a great segue to our next question, and that is, many of you have talked about opportunities. Some of you have also talked about pretty significant challenges. I think this audience would really be interested in hearing the suggestions that each of you has for the next 4 years for students and health professionals who are committed to improving the state of minority health. What can we do to make a difference? Who'd like to start?
I would like to just reemphasize what I said earlier, and that is, and build on what Dr. McBride said, is that there are a lot of people in those communities that hold the power. And I think as health professionals, we need to help them realize the power that they have. We have Medicaid and a lot of other programs for folks who are disadvantaged, but some of those folks don't even utilize those resources. And to be able to utilize those, they have to understand how the system works and how to access the system. And I think as healthcare professionals, that's part of our charge, is to help the folks that we deal with realize the power that they have and be able to utilize those resources for those folks and help them get what they need in their communities.
So I'd like to address this from the perspective that basically I spend most of my professional life looking at is in building funding and looking at proposal development to impact on getting to where you want to go. Everybody needs money. And I will share with you that for the last 14 years, I've gone to Cook County Hospital in Chicago, which represents the greatest of disparities in our healthcare system. And I go twice a year and spend at least 10 days each time to help them impact on asking questions that will help them impact policy that will get them to where they want to go. So you need to start to look at ways in which you can build coalitions and activate your communities so that you can access the dollars that will be available in a way that will help the populations you're going to work with. The Bush administration has indicated that they are going to increase funding to CDC for Bill's salary, to the National Institutes of Health. They're going to increase funding for research, but all of those different initiatives have been also focused on increasing dollars and access and partnership with the private sector. While on one hand, that may be good, on the other hand, one of the things that you have to be aware of as a health professional is that the private sector very rarely has to be accountable to any larger resource other than its own industry. So that you need to know who's coming into your communities, and you need to help through your health centers and building community coalitions to understand how those partnerships can be formed and who can come in and ask the questions of the people that you're going to work with, because that's a very important factor. Two other areas that they're interested in, when we talk about faith-based initiatives, I have a lot of concern about that. Churches, synagogues, Native American communities, Muslims, Hindus have been taking care of their communities for years. They don't need the government to come in and tell them how to do it and the way to do it. What we don't want to see is monies taken away from the communities themselves to have certain appropriate kinds of faith-based initiatives dictating how health care can be accessed and to improve health status. For example, in Texas, two major initiatives that were proposed through the Bush administration. One was dealing with families, and it was called Strong Families. In that particular program, monies were supposed to be taken from government initiatives to give to the private sector to deal with abstinence, $6 million for 32 programs across the state the size of Texas, and that's supposed to deal with prevention. But really what it was for was to preach a particular kind of venue of thought. When we talk about private sector dollars and tax relief for the private sector, pharmaceuticals were mentioned, we have to look at how that will impact on Dr. McBride's shop, because if there's decreased amount of taxation to the private sector, there's decreased tax dollars available for public health kinds of programs that are currently in place. So what he is telling us in terms of being entrepreneurial means we have to meet the challenge of those kinds of approaches by knowing how to make the spin, to build the teams, to go after the dollars that makes us able to continue the services that populations need that we work with. And that is going to be a major challenge for all of us in this next administration.
Having spent many years in the classroom, I think I'd like to address this from an academic standpoint. What suggestions do I have to you as students? First of all, you know I'm from the Environmental Institute, and we have just about determined that probably 90% of diseases and morbidities have an environmental component. So I would suggest that you choose a career in environmental health, whether it's toxicology, epidemiology, biostatistics, environmental microbiology, because all of these areas critically address health disparities in particular. So I would suggest that you do that. I would suggest that you also strongly encourage those who find academic medicine interesting, for those individuals to do that, especially racial and ethnic minorities. Because as we move to the next level of trying to understand disease and trying to identify prevention mechanisms, we're going to have to go more to clinical trials. And we're going to have to make sure that everyone is involved, or everyone has the opportunity to participate in clinical trials. And given the history of Tuskegee, we have to make sure that they are ethical individuals, culturally competent individuals involved in those trials. So I think biomedical research, clinical medicine, academic medicine, these areas are very, very important. Also, I want to say something about the faith-based initiatives. You know, it's interesting that that would come up as a new initiative. It is an old, old initiative. In 1906, Du Bois wrote about health disparities. And in 1915, National Negro Health Week was initiated. And it continued with the basic emphasis being in the church until 1951, when integration occurred, and the idea was that now that we have integration, we don't need to focus on this issue separately. But in fact, some of you might have seen the article just last year that showed that health disparities are greater now than they were in 1950. And if you think that 1951 was when the focus on Negro Health Week ended, and you see where we are now today, it says something about history and how you forget history. But the point that I want to make is that for over 10 years, the National Institutes of Health has really made a great leeways into reducing some forms of health disparities by going to the black church. This is our community, and when we talk about community partnerships in the black community, it is through the church. Now, I agree that as this is expanded, that we have to be very careful of what churches take advantage of the faith-based initiatives, and I agree with you on that. But I just want to be clear about the fact that in the black community, the involvement of the black church in the community is very, very important.
Oh, well, I'm going to be nice.
Oh, no, don't.
I guess I get hung up sometimes when, I'm hung up on numbers, and I think numbers are very important. I think it's extraordinarily important that we have people who can analyze data. And I think that in terms of the so-called leaders that we've had to this point, they don't tend to be very strong in that area. And the result is I think we tend to be misled in a number of areas. And I think if the challenge for this generation is going to be to create a whole new way of developing leadership and providing leadership to all ethnic communities, including European American communities. Because I think there's a tendency to move on what's in a soundbite rather than taking the time to understand what the data is telling us about a number of these problems. Now, in terms of the disparities, there's a little exercise I do in my class. I ask my students what was the relative risk of infant mortality, black to white, in 1900, and I asked them if it was 2, 4, or 8. If black Americans were 2 times greater than white Americans in 1900 to have a baby die in the first year of life, 4 times greater or 8 times greater. And most people say it's 6 or 8. And then I asked them if it was in 1940, what was it? Same thing, 2, 4, or 8. And in 1980, what is it? 2, 4, 8. In 1990, 2, 4, 8. Well, in 1900, the rate ratio was 2. In 1940, the rate ratio was 2. In 1980, the rate ratio is 2. In 1990, the rate ratio is 2. And in 1999, the rate ratio is 2. The gap that we're trying to close has been consistent for 100 years. Most people don't understand this, some basic, simple facts about what we're struggling with. The overall rate has gone down precipitously over the last 30 years, but the gap has remained the same. So one of the real problems that bother me when you're talking about these kinds of issues is there are too many people who do not understand the basic issues in some of these problems. And it just concerns me greatly that people don't understand some of these basic issues. I do think politics get me upset. I admit to that. And I do think there are things that we have to be concerned about over the next year. One of the things that we have to deal with is, one of the reasons that gap has been consistent is due to racism in America. Racism is still a major force in America today. Among white Americans, there is white privilege, and most white people will not admit that they have white privilege in this country. So the result is you have black people who see that white privilege and gets ticked off every day that they see it. So their blood pressure go up. Okay? Under the current political situations, politicians have learned that you can fool the black community on a number of issues. You can fool black people on the issue of race because many black people function in a way that's racist. They say that if a Supreme Court justice has melanin in his skin, he must be black. And therefore, we have to identify with him because he is, in quotes, black. Or we could find a black assistant attorney general, or someone who has melanin in their skin, and presume somehow that that person is going to do anything more for the black community than any white conservative will do. And the idea is that they could take advantage of that because they have had experience in knowing that if you could find someone with melanin who could act white, they can achieve the same objective as having a white person who's white. So I think what to challenge to me is that we must learn to be analytic. And that is going to be a great challenge. This is one of the places where you can learn to be analytic. And it is important that you take the time to do that. One of the first comments was absolutely correct. The administration may not make a big difference one way or the other on any of these issues. Israel will get its money, no matter what administration it is. And it is because the political organization that makes certain that that money goes there is well organized and it is consistent. And that is really what the issue is having an organization or a people analytic and organized and consistent in trying to close this gap.
Thank you. I'd like to ask the panelists for any final comments. If you have anything burning you'd like to say, I definitely want to leave time for some questions. Dr. McBride?
I wanted to comment on the question in terms of how would you deal with what the future is and all that stuff for folks, what I'm looking for. I think that, first of all, my advice would be to follow what you like and what your talent is. I mean, that's important, that you have to like what you're doing, and you have to be, if that's where your talent is, go that way. I have to disagree a little bit with my colleague in terms of I agree with him strongly that there's a need for leadership, that there is this big need for leadership and development of leadership, and universities and schools, high schools, public schools, and whatever have been very poor in developing leadership. So leadership, I feel, is going to be the most important thing. Analytical leadership is wonderful. However, a diverse leadership is important. That we need diversity in talent, not necessarily only ethnic diversity, but diversity even within ethnic groups of talent. There's some of us, we need people that are not going to let the facts get in the way, okay? Because most of public health, truly, you don't know the answers in public health, and you have to take action even if you don't know the answers in public health. And the question is, the issue is often the question, not the answer. And infant mortality, you haven't mentioned one of my things, it just drives me crazy. I'm tired, and I've been listening to all these and looking and analyzing all these untoward differential effects and infant mortality and things of the sort, black, white, and all that sort of stuff, all my life in terms of that. And I'm sick and tired of it, quite frankly. The differences, I've known the differences have been parallel, these lines have been running parallel, but we have not phrased the question properly in terms of what infant mortality, what does it really mean in terms of it as a statistic. So when Marian brings up the idea of environment, and people kind of, like snickered, we have to think in terms of looking at this in a whole different way. It's not necessarily going to be health services. It's not necessarily going to find a toxin in the environment that's going to explain why incidences of cancer might be higher in one group versus another. Or it might be something it might be something ethically or religious. It might have some answers. There might be some answers that are found in China and Africa in some sort of natural remedies. But we have to approach this in a different way with some amount of zeal and commitment, and take the cards play the cards as they lay right there, not as you wish they would be. So I would look for, if you're looking at your state health director, what I look for is a critical need for leadership, no matter at what level it is. I strongly respect community leadership, a person who can deal and understand how communities work and things, and also as well as a person who can deal with the office politics in these big bureaucracies that we got here in Raleigh and in the Triangle and in Washington.
Thank you. I think all of you have raised some very provocative points, and many people have traveled a long way to be here to ask you questions. So at this point, I'd like to open the floor for questions from the audience. If you would go up to the microphones, we've got microphones on either side. And if you could please just speak up and be concise so that we can have time to fit everybody in, that would be great. You can direct your question to a specific panelist or to the panel in its entirety.
Good afternoon. My name is Jacoby Wilson. I am an environmental health major, so one of the few who are looking at the environment. But what I want to say is, since I just brought up the environment, we have several appointees who have strange track records to be in certain positions now in the Bush administration. We have Ms. Gail Norton. You also have Ms. Whitman from New Jersey. Looking at environmental health and the environmental issues, and looking at some other health issues, what do you think about the challenges of Bush's appointees? What kind of challenges are they going to have to meet, since their track records historically in their whole life, their whole careers, they've gone against the things, the dominant policies, the dominant culture that we have in America. You know, we have people who want to have pro-choice. People who want conservation, preservation of natural resources. People want to look at AIDS prevention. But the positions, the people who fill these positions have very different qualifications, very different records. So how you feel about that? Sorry for being so long-winded, but that's my question.
So the question for those of you who are checking in by satellite is, what challenges can we expect, or what's the opinion of some Bush appointees who have inconsistent track records in terms of voting in positions on environmental and health-related issues?
Well, in terms of the environment, I would say that it's probably going to offer some difficulties in, if you talk broader policy, national policies, it's going to offer some difficulty because basically a lot of national policies are driven on how strongly they're enforced by the leadership. So some of those things you mentioned are correct. However, let's cut through the chase and let's start to deal with the issues that I just brought up. How are environmental policies that we have to worry about here, right here in this room, how are they set? And you're going to find that most of your environmental policies in those conditions that we live in are controlled by local, county, city, and state kinds of entities, and not necessarily even through environmental health entities as well. So it might be one of the great effects of environment are your planning boards, your county and municipal planning boards. They do a lot to dictate air pollution and ability to walk to places and things of that sort. So you have to look, if you have a career in environmental health, there's all levels that you can deal with in terms of environment. You could probably have more to say about an environment by taking on a position in a county environmental health unit than you will at some state or in some federal bureaucracy hidden away somewhere in Bethesda. So again, the bureaucracy is, the federal government has been, especially in EPA and these other environmental organizations, they have been hands-off for a long time. I mean, it's been a long time since you've had sort of a interventionist type of federal bureaucracy. You'll find that most of your progressive environmental policies are at the state level and below.
I'm probably the oldest one on this panel except for Dr. Schwartz. So I think what I want to do is, I sort of took the role in terms of funding and research to impact on policy that will address some of these issues, whether it's environmental policy, health disparities, health access, status, health services and care delivery. But when I go back to the 1960s, and I worked with the Panthers setting up the free breakfast programs in West Oakland and in Chicago with Sal Alinsky and organizing communities. We had a sense that the only way we could really create change was through forming these community coalitions and bringing the lights on, the telephone so that the AIDS office doesn't close. I think that what we're all saying here together is that while we need diversity in leadership, we also need diversity that is both analytical and critical, but also that is active and provides advocacy, that knows the ropes and how to join communities so that you can continue in the fields that you choose. If you're not going to be active, if there's no response, then there is no need to continue these programs, because that's how you field test to see whether you're going to close something. That's what they did in the 60s, and that's what's happening now. So it is up to us to understand what it is that needs to be done and how to make it happen. You can't just be a health worker sitting in your office and reading the statistics and saying, well, I can do this because they've moved the money around. That's how Ashcroft got appointed. People talked, and then he just got appointed, no matter what his record was. So you have to deal with that now, and you choose professions. Well, as I tell my children, you don't create change from the outside, you create change from the inside. That's what an activist is all about. That's what advocacy is about, and that's how you build programs. You understand the issues, you attack the issues, and you deal with the people and listen to what they have to say to help them organize, or for them to organize you so that you can make sure that you can continue funding in areas that allow public health to go on. Without money, there is no public health. Is that correct? And you can close programs. I mean, you can make enough of a dent. We saw that in the Reagan regime, where it took years to start to build up access to health care. So I wouldn't play it small time, guys. This is big time now. We're being faced with the real issues. And I can see Vic down in the front shaking his head, yes, and that's true. That's right. And we're talking about environment. We're talking about the logging, okay? When you start the logging again, and then you impact on the water, and then you don't have clean water, and then you have increased tuberculosis. And if you have increased tuberculosis and other infectious diseases, and then there is a trickle-down effect, but it's not communism. It's dealing with these issues. So that's what, don't look at them in isolation. Look at them in terms of broad-based picture. Some of you will go in to positions in leaders in health departments. Some of you need to get involved in coalitions, grassroots opportunities. Some of you have to propose doing research, and that research is asking questions that impact some policy. Some of you will become writers, but whatever you do, you need to advocate so that public health meets the needs of the people, and that is your challenge.
I'm going to intervene to make sure that people who want to ask a question have a chance.
Yes.
Hello, I'm a current medical student, and with learning all the current disparities that exist now and have existed for so long with our current healthcare plan, I was wondering how many of you would advocate for a national healthcare system, and what would you think? What would you think the outcome that would have on quality and access to care?
Well, we have. Shall I take this one?
Go ahead. Go right ahead.
There have been 5 efforts in this century to enact some kind of national health insurance system under both Republican administrations and Democratic administrations. Every single one has politically failed. The prospects of a national health insurance system, let me first answer your question as to, do I think we should have a national health insurance system? We are the only country in the 24 countries of the OECD which does not have either a national health service or insurance system. And we are told that the reason we don't is because we are special. My response to that is yes, we're specially bad. So I don't think people who are in the health field, anybody would say we shouldn't have a national health insurance system. The question is, given the nature, and I'll just leave it at this, because I'm talking to you as a political scientist. If someone were to ask me why, what is the really fundamental systemic reason why we have never succeeded in getting one enacted, and we are unique in that respect, it is because the nature of our political structure and political public policy process is such that power is so decentralized and so diffused that the analogy I always made to my students was the guy who's running field and track, with the hurdles, and they've got to get over every single hurdle to get to the finishing line. There are so many multiple opportunities, okay, and so many access points in the public policy process for an opponent of any legislative initiative to intervene, and that opponent only has to intervene at one point and it's dead. But the advocate of change has to win every single hurdle, get over it, and get to the finish line. And in the nature of our system, whether it be health insurance, or whether it be affordable housing, whether it be rebuilding all of our schools in the cities which are crumbling and are falling down, you don't get change because our forefathers designed a system purposely to prevent as much as possible the central government from being proactive, in fact, oftentimes from being active at all. But I just want to conclude on this one note. This is really a challenge to every single one of you. One of the nice things about being old is I got to retire from the university on January 1st of this year. And so now I can say anything I please. And I don't have to worry about any retaliation because they can't do one thing to me. And so I just want to let you in on what I think is the only solution to all of these problems, okay? I don't know how many of you know the name Václav Havel. He was the founder of Forum 77. He's now the president of the Czech Republic. He was a dissident who constantly exposed the corruption, the dishonesty, the illegality, the repression of the Czechoslovak government. He was constantly thrown in jail. And he wouldn't be out one a day, and he continued that, and he'd be thrown in jail again and again. Finally, when the communist system collapsed, and he was then elected president, there was a press conference, and somebody asked him, President Havel, why did you continuously speak and behave the way you did, knowing that you would immediately be thrown in jail and repressed? And this was his answer. And I think every single one of us in this room has to think about it in terms of what you and I will do. He said, any person who does not expose and criticize totalitarianism bears a moral responsibility for its existence and perpetuation. And anybody in this society which doesn't expose and criticize the racial disparities, the lack of health insurance for 42 million people, the complete ignoring of the AIDS epidemic in the African American community, that every single one of us who is silent and does not engage in what I call grassroots political screaming and yelling, we bear a moral responsibility for that injustice, that disparity, that ignorance, its continuation and perpetuation. And by the way, just one more thing. If you go back to the very beginning of the AIDS problem, you know that little group called ACT? A lot of things they did, they got negative media publicity. But I'll tell you what's worse than getting negative media publicity: getting no media coverage at all. So if you want to do something as an individual, get out there at that grassroots level and engage in political yelling and screaming. And that's the best thing that all of us can do.
I'd like to address the point of whether or not a national health care plan would serve to eliminate health disparities. I don't know how many of you are familiar with some of the studies that have gone on Army bases, where individuals presumably receive the same kind of health care. Well, my area is breast cancer research. And you probably know that while more white women get breast cancer, more black women, percentage-wise, die. Right. It's the same thing on the Army bases. So there's something else that's causing this occurrence. So what I'd like to suggest is that if we think about some of the recent studies, one close to home last year at Duke, where cardiovascular patients, whether they were black or white, they got different treatment. And we've seen the same kinds of studies with renal kidney diseases and a number of other studies to show that the health care, even though individuals have access to it, that there's a different quality of health care given to individuals based on their color. And so when I say environment, I'm also talking about attitudes, behavior. I'm talking about racism, racialism. So I think that even with a national health care plan, we're going to have some of these same kinds of attitudes. And it's very important that we really address those attitudes.
Thank you. One more question.
I'm John Hatch, retired professor from this institution. I currently work for the General Baptist State Convention. I have a question that I would like to direct to Dr. Jenkins and also to Dr. McBride. And Dr. Jenkins, it has to do with your own education in the Department of Epidemiology at UNC Chapel Hill. People in your department pioneered in the whole notion of psychoneuroimmunology and the notion that the quality of relationships within families, within communities, if absolutely nothing else can happen, that this would add some dimension of immunity to those people who are coherent, focused, consistent, have values, et cetera, et cetera. And I'd like to couch this in the framework of research done by people like Oscar Lewis, who thought that coherence would give health, and John Castle and Sherman James, who've done research in these areas. And then I heard Dr. McBride say that maybe faith could be a part of whatever it is that we do to improve health. And I would like to ask these two panelists if they would respond to that dimension of things that people can do exclusive of anything the public health establishment or the national academies might wish to do.
Well, maybe I can combine this, put in a bigger context. If you were to do a model of the gap, what you will probably find, and you did a literature review, you would probably find what somebody once wrote, okay, it was me, that there's a 30-30-30 rule, that 30% of the gap is probably due to socioeconomic status. The 30% of the gap is probably due to discrimination, racism, both through health services as well as through the stressors of racism. And 30% is due to issues of behavior, culture, faith, and so on. So how much of it is affected by health services is a lot less, a lot less than people think it does. The only people who believe it has a lot to do with the gap of people who are health providers. In terms of this issue of faith and social support and interaction is extraordinarily important. One of the most interesting phenomena is what is sometimes called the Chicano paradox, where Chicano women who have less education, less money, less access to health care, have healthier babies than European American women, or at least as healthy as European American women. And a lot of it has to do with faith and social support and a lot of other factors. So I think that this is an important area of research that needs to be done. And based on what we already know, that there's a lot of important activities that can occur through this whole idea of faith. Now, when I say faith, I don't necessarily mean churches, though, Dr. Hatch. But I do mean issues of faith and social support among individuals. I think it is a much bigger issue than one might presuppose in our so-called scientific age.
Well, very briefly, I agree with Dr. Jenkins, and I think those questions, Dr. Hatch, are very well presented. I think we're understanding now more that I think in this book, Ehrlich, in his Human Natures, mentioned that we have, at that point he was thinking we had 100,000 genes, and now we know there are only 30,000 genes, human genes, and we have more than 1 trillion neurons, and that would mean one gene would control billions of neurons with the synapses and all that. So our brain can override our genetic, and then what comes along with that is culture and belief. And we in our sciences and our linear kind of thinking have had the idea that we had the answers, and that other things didn't really have much of a relationship to what we thought were the answers when we talk about communicable diseases, health, life expectancy, and the like. But many cultures, China and Africa and Latin America and other places, have a different approach towards health, a different approach towards remedies and dealing with sickness and illness that have some effect and that do work. And we're just now opening up our eyes to understand what this means. And we can't necessarily hold this to the microscope and things, but we have to be open to that there are hosts of other protective things that people do no matter what. I'm a physician. I know good and well when I was in the writing prescriptions, that you'd write a prescription and that might or might not get filled depending on who that person asked about that prescription, that medication work, and what have you, and the context of where that medication was given. So people make choices that are well beyond what we think they're going to do in terms of health. And so I'm a little bit jaded. I agree with Marian in terms of that. Just the straightforward health effects are going to have a marginal, I feel, are not necessarily marginal to the disparity gap, but there are a whole host of other environmental, cultural, social, and political issues that have to come to bear before we indeed close the gap between all of us here.
Great, thank you. I'd like to just take a minute to thank all the panelists for being with us today. As promised, this was very provocative, and I think we could probably go on for 3 more hours. But as we prepare to conclude the conference, I'd like to introduce Andra Shields. Andra is Associate Dean for Student Affairs at the School of Public Health, and she's planning to just share some final comments with us.
Good afternoon. I am Andra Shields, and as Dean of Students at the School of Public Health, it has been my immense pleasure to work with the Planning Committee, the students and volunteers, in bringing you this event today. All of the committee members are to be commended for their efforts in bringing you this opportunity, and that's how we view this conference, as an abundance of opportunities that we bring to you. Opportunities to teach, to learn, to share, opportunities to make new friends, new connections, new colleagues, opportunities to reconnect with mentors and classmates and peers. I've seen all of that happen today, so I know that you've taken advantage of these opportunities, and we thank you. This is the 3rd conference in which I've been involved, and I must say it's heartening to see so many returning attendees mingled with new faces. We look forward to seeing you all at next year's event, the 24th Annual Minority Health Conference, which will be here at the Friday Center on Friday, March 1st, 2002. So please mark your calendars. At this point, I'd like to say thank you to some other people who have been very supportive and without whose help this event would not have been such a success. First, to the conference attendees, those in-house and those who are joining us via